pleasure to be here today. Going to turn a little bit more towards the technical procedural side of treatment of brain metastases and talk about brachytherapy, which is the specific use of insertional radiation sources into tissue to deliver radiation from the inside out. And the focus of the talk will also be on the nature of the interdisciplinary approach to treatment of brain metastases. I have no relevant disclosures. So next few minutes, I'll talk about the increasing relevance of retreatment of brain metastases in patients, some of the technical challenges we face, specifically the role of CNS-directed brachytherapy, and some future directions. So in general, our upfront management of patients with brain metastases is very much interdisciplinary and very much based upon the individual features of both the patient and the disease. So we frequently will employ surgery for bulkier lesions, for lesions that are symptomatic, lesions where tissue may be required. Historically, for patients with multiple brain metastases, we would employ comprehensive radiation approaches, such as whole brain radiation therapy. Unfortunately, that comes with significant, in some cases, catastrophic morbidity to patients' neurocognitive function and quality of life. So we've shifted over time, especially for patients who have more limited burden of disease, to focal radiation approaches, and that includes stereotactic radiosurgery here at UCSF that's most commonly delivered with our Gamma Knife platform. But as you've heard, there are now emerging CNS penetrant systemic therapies that are available that may enable us to defer, in some cases, radiation or synergize with radiation. And then for a subset of patients with a very high burden of disease, supportive care may be most appropriate. So for most patients with limited numbers of volume of brain metastases, radiosurgery is preferred, and that's shown here on the right, a patient with 2 brain metastases treated very focally with radiation, and over time, you can see decreased volumetric appearance of these lesions, and in some cases, complete resolution. We know that local control of lesions following radiosurgery is good to excellent. And there are a variety of high volume studies that have been performed, some prospective registries, some in a randomized setting looking at particular questions that show patients treated with radiosurgery, especially for smaller lesions, will have about 80+% overall local control. This is what I would now consider a historic study done in Japan, looking at patients with multiple brain metastases. And at that time, the local control is excellent, but as was remarked by Dr. DeGroot this morning, the median overall survival still remains limited, and at this time is about a year or so for patients of different histologies. Also, this study really employed treatment for smaller tumors. So where you can treat smaller tumors with dose escalation, you can achieve excellent local control. But when we look at the compendium of more modern studies treated over time, where there's a radiosurgery arm alone, the local failure rates, especially for folks who have more radio-resistant histologies, melanomas, renal cell cancers, larger tumors, local control may be on the order of about 70% or so. And that's shown in a variety of studies, including this study that really looked at the benefit of radiosurgery alone versus radiosurgery and whole brain radiation to preserve neurocognition. So what we do know is that if we're able to dose escalate, we can achieve improved rates of local control, shown here in this Cleveland Clinic study, that as we increase dose, we can decrease the rates of local failure. The challenge is, even with this very focal radiation technique, we can cause radiation injury, which in and of itself, while focal, can be devastating. So there's a continuum of changes that occur post-radiation, some of which can be transient, some of which can be more long-term and devastating, causing brain radiation necrosis, especially at high doses. And that will require interventions such as pharmacologic or even surgical debridement of the tissue and have significant morbidity. So we're somewhat limited in our ability to dose escalate. And we've begun to understand this, and so we have dose volume parameters that guide our ability to deliver radiation safely and as effectively as possible when we're performing radiosurgery. Shown here is a meticulous study by Dr. Penny Sneed in our department a few years ago that really emphasizes the fact that it's a function of both size of the lesion that's being treated, as well as prior radiation that can increase the risk of what we call adverse radiation effect, radiation necrosis. And that's very important when we're considering retreatment, because so many of the patients that we're retreating have had prior radiation treatment. So we have good consensus guidelines now, especially in the setting of a limited number of metastases, that shows us that the local failure rates 1 year post-radiosurgery are on the order of 20–30%. So I'd say they're good, not as excellent as we would like. And in our review, when we're looking at patients, we're more commonly here at UCSF treating patients with what I call multiple brain metastases. So on the order of 5 to 10, sometimes even 20, given the technical precision that's afforded by radiosurgery approaches. And it's important to recognize that what we're interested is in patient outcomes, not just the local control per met. And as we're treating patients with more metastases, the local failure per lesion gets magnified in terms of the local failure per patient because patients have more metastases, and statistically it's increased likelihood that they will have some failure amongst the constellation of metastases that are treated. The other thing that's important is we are making some strides overall as a community in terms of patient overall survival in the subset of patients with brain metastases. There are a number of studies looking at prognostication, stratification by patient-specific and molecular-specific features of disease. And we see that where in the older era, maybe 10, 20 years ago, median overall survival was on the order of 9 to 12 months for many patients. In select patients, patients with targetable mutations in lung cancer, breast cancer, we see patients living in excess of 3 or more years. And that's important because what we see, and this is an example in our practice, a patient who had HER2 positive solitary brain metastases treated in 2014 with gamma knife radiosurgery, followed over time, apparently NED, but 5 years later had seemingly a recurrence, was first treated with bevacizumab because, as I'll note, it's sometimes difficult to distinguish what might be transient or permanent radiation changes, treatment effect, radiation necrosis versus progression, but had this treatment, and then essentially the tumor declared itself, and it was very clear that there was progression now 5+ years out from their initial treatment. So patients are living longer, and that gives us more time to see potential local failures. We also have newer systemic agents. You're hearing from a number of folks today that have CNS penetration. You see this in the HER2 CLIMB trial, the addition of dacatinib to trastuzumab and capecitabine, improving CNS progression-free survival. You heard about this in melanoma from Dr. Dowd earlier today. Also within lung cancer, a number of studies using tyrosine kinase inhibitors of better CNS efficacy, showing control in the CNS for brain metastases. But importantly, in our realm, they may not just offer better local control, but they may interact with radiation in a way to potentially augment the risk of radiation injury. And so a number of papers have emerged calling for some caution with concurrent administration of both these targeted immunotherapy agents and high-dose radiation. So I hope I'm convincing you that the need for retreatments becoming increasingly relevant, because for radiosurgery, we can't always dose escalate. It's just not feasible for optimal local control. We're commonly treating patients with multiple brain metastases. The local control per lesion is not the same as that per patient. Patients are living longer, and there's no plateau. We can continue to see local failures accumulate over time, and that is the reality of our practice. So there's a number of challenges that we observe with retreatment, and one of them is timing. So you'll hear briefly from me, but then more extensively from Dr. Villanueva-Meyer about the difficulty in radiographically distinguishing progression from what might be transient or permanent radiation changes. It's a big focal point of our interdisciplinary discussions. There's safety, where we have not yet established what is the normal tissue brain tolerance with retreatment. There's also the potential for, in these heavily pretreated patients, intrinsic or acquired resistance, not just to systemic therapies, but also to radiation. We recognize there's increased risk of subsequent treatment effect or radiation necrosis with prior radiation. We don't know how this is interacting in the background of targeted agents and immunotherapies, and there's a lot of technical considerations from our end to consider. So just very briefly, and you'll hear more about this, when we're evaluating patients who've received radiosurgery, very commonly there are at least temporary changes, swelling of lesions, edema that we can see that are consistent with actually a treatment response, but it's not always so clear, even despite multiparametric MRI, biologic imaging. We don't have great sensitivity, specificity to easily delineate whether radiographic changes are consistent with treatment effect versus tumor progression. We rely heavily on our colleagues in neuroradiology to help us with this. So basic principle, how do we approach retreatment? We need to address the recurrent disease. We have patients who've had significant prior therapy, prior treatment, and that means that the therapeutic window for subsequent treatment is more narrow. So we need to employ techniques that can widen that window as best as possible. So brachytherapy, which is the use of active radiation sources, can be very effective for retreatment. And I show an example of a brachytherapy. We call them seeds. Here they can be stranded into surgical sutures. They're relatively small. They look like little metal filings shown there next to a Liberty dime. They're encased in an inert biocompatible packaging, and they can be implanted with the help of our expert neurosurgeons during a planned resection. So these are patients who've had recurrence who would be amenable to resection. We can coordinate and pre-plan to be able to place these seeds in at the time of planned a resection. And the strength of this is that they're delivering radiation from the inside out. So we can deliver very high dose, very conformally, and very effectively in a way that is at least on par, if not potentially more powerful than what we can deliver with radiosurgery. This is not a new technology, but it's evolved over time. So UCSF actually historically was one of the first groups to report on the use of CNS brachytherapy for a variety of indications, including metastases, and that's shown here. And in the initial studies, what was shown is it's very effective, or can be very effective, in the presence of patients who have had prior radiation and prior surgical procedures for treatment of brain metastases. But there is this risk of perioperative complications and risk of radiation injury with some of the older techniques that have been employed. Since the initial reports, there's over 30 studies that have been published in this space. We've evolved in terms of the nature of the isotopes that we're using to deliver the radiation more quickly. That can be potent, and we're prescribing very high dose, up to 80 gray, to a depth of 5 millimeters in the cavity surrounding the resection. So this is an example. This is a patient with a radiation-resistant urothelial cancer with a left cerebellar met, which received, in this case, fractionated radiosurgery early on, had a good response at 6 months. At 12 months, had some evidence of recurrence, and that was made clear by 16 months. And this patient underwent re-resection, or a resection with planned brachytherapy, and was well tolerated. And there are now increasing reports. This was one of the first that came from the Cornell Weill experience with Rochester. Excellent local control in the retreatment setting, 83% freedom from local progression. But we still see a fair amount of distant failures. In our experience, this was led by Will Chen, who's here. I'll be speaking later today on another topic. Also, excellent local control, very limited cases of long-term radiation injury or radiation changes, most of which were self-resolved. So this is a very powerful technique that we have at hand, although you can see it's very limited numbers thus far reported. So back to that patient that recurred post 5 years. This patient underwent a resection with Dr. Theodosopoulos, and we placed brachytherapy implant seeds at the time, again, well tolerated. So our general approach, just to close, we're very much focused on interdisciplinary management. We think about patients, are they amenable for resection? Can we do brachytherapy? In some cases, we consider reirradiation. You'll hear more about lit therapy from Dr. Aghi. Although we usually wait some interval before considering reirradiation, and we still don't quite understand the role of systemic therapy, how it interfaces. So we generally hold this for some time during the procedure. So I hope I've convinced you that the indications for reirradiation are increasing, that it can be safe and effective, but we approach it cautiously on a case-by-case basis. Techniques such as brachytherapy can minimize the risk of toxicity of reirradiation. There's a lot to be done in terms of future directions to early detection so that what we're treating is a smaller target volume over time. And there's an opportunity to optimize the parameters from a growing data pool, and we're soon going to open a multi-institutional registry for other specialized institutions doing this type of work. So with that, we have a number of contributors to this work, and I thank you for your time.